The objectives: by the end of this lecture, we should be able to read a partograph, record the findings on a partograph, diagnose the partograph abnormalities, and manage the patients with abnormal partographs. You see, this is a blank partograph. You can print it and practice the cases mentioned in this lecture. Case number 1. Mrs. Layla Ahmed, a 25 years old, gravid 2-para-1 woman, admitted on the 1st of October at 10 a.m. with labor pain. On examination, temperature 37 centigrade, pulse rate 88 beats per minute, blood pressure was 20/70 millimeter mercury, fetal heart rate 140 beats per minute, uterine contractions 3 per 10 minutes, each lasts for 35 seconds. The fetal head is 5/5 palpable. PV examination, the cervix is 5 cm dilated with intact membranes. Plot these findings on the partograph. You can stop this video and record the finding, and then you check your answers. Here, to start with, these are the patient's informations. Here, this is the 0 time. The cervix was 5 cm dilated, so we start on the alert line because the patient entered into the active phase of labor. The head 5/5 palpable, amniotic fluid intact membranes, and the fetal heart 140. Note that the records should be at the same time of examination. Regarding the contractions, you see here she has 3 contractions in 10 minutes, each lasts for 35 seconds, so here lines. Maternal observation, again at the same time, the pulse rate 88, blood pressure 120/70, and the temperature 37. After 4 hours, this woman, the temperature 37 centigrade, pulse rate 90 beats per minute, blood pressure 130/70 millimeter mercury, fetal heart rate 130, uterine contractions 4 in 10 minutes, each lasts for 45 seconds, fetal head 3/5 palpable, PV 7 cm dilatation, ruptured membranes with a clear liquor. Plot these findings on the partograph. Again, you can stop this video and plot your findings, and then you check your plotting. After 4 hours, this is the first hour, each 1 square equals 30 minutes, so that this is 1 hour, second hour, third, and the fourth hour. In the same time here, the cervix is 7 cm dilated, the head 3/5 palpable, clear amniotic fluid, the fetal heart is 130 beats per minute. The contractions, 4 contractions in 10 minutes, each lasts for 45 seconds, so we fill the whole square. The maternal observation, again here the vital signs and the temperature. For the same patient, after another 4 hours, temperature 37.5, pulse rate 100 beats per minute, blood pressure 140/80 millimeter mercury, fetal heart rate 100 beats per minute, uterine contractions 5 in 10 minutes, each lasts for 55 seconds, fetal head 1/5 palpable, PV 7 cm dilatation, ruptured membrane with meconium stained liquor, molding 2 pluses. Urine volume 200 ml, protein 1 plus. Plot these findings on the partograph. Here you see, after another 4 hours, 5, 6, 7, 8, the cervix 7 cm dilated, the head 1/5 palpable. You see the fetal heart becoming 100, meconium stained liquor, and molding 2 pluses. So if I ask you, what are the abnormalities in this partograph now? The abnormalities are fetal bradycardia, meconium stained liquor, molding 2 pluses, secondary arrest of cervical dilatation. These are the abnormalities seen now. Regarding the contractions, you see here 5 contractions, each lasts for 55 seconds. Maternal vital signs here, temperature here, urine volume, and protein. Note that the contractions should be recorded every half hour. Every 30 minutes we record the contractions, okay? Again, the maternal pulse should be recorded every half hour like that, and then we connect between them. Case number 2, Mrs. Yasmin admitted to the labor room with labor pain. She is a 40 weeks pregnant primigravida. On examination, the head was 3/5 palpable. The cervix was 5 cm dilated. The membranes were ruptured spontaneously with a clear liquor. Observation after 4 hours revealed the following partograph. Woman, you see that this is a normally progressing labor. As far as the labor progress is on or to the left of the alert line, this is a normally progressing labor, so no need to interfere. Put in mind that if you have inefficient contractions, the efficient contractions, 4 to 5 contractions in 10 minutes, each lasts 40 to 50 seconds. If you have inefficient uterine contractions, but labor progressing normally, again you should not interfere. Case number 3, Mrs. Hiyam Ali is a 34-year-old woman, para 2 vaginal deliveries, pregnant 38 weeks, presented with labor pain on the 3rd of July at 10 p.m. On examination, fetal heart rate 130 beats per minute. No fetal head was palpable abdominally. The cervix was 4 cm dilated with intact membranes. 4-hour observation revealed the following partograph. You see this is the dilatation here, 1 cm after 4 hours, and the minimum required is 2 cm in 4 hours. So this is a poorly progressive labor. In this case, as far as the membranes are intact, we can do artificial rupture of membranes. Then if the patient having inefficient contractions, you can give oxytocin. And the next vaginal examination should be after 2 hours rather than 4 hours due to abnormalities in the progress of labor. Case number 4, Mrs. Maryam, a 34-year-old patient, pregnant 39 weeks, presented with labor pain, fetal heart rate 140 beats per minute. The head was 5/5 palpable abdominally. The cervix was 4 cm dilated with intact membranes, no molding. This is the admission partograph for this woman. Here on admission, 4 cm dilated cervix, the head 5/5 palpable, intact membranes, no molding, fetal heart 140 beats per minute. After 4 hours of active labor, the fetal heart 140 beats per minute, A&M revealed a clear liquor with the following partograph. After 4 hours, this is 1, 2, 3, 4, the cervix become 8 cm dilated, the head 5/5 palpable, clear liquor and no molding. Here the contractions, 4 contractions that are efficient contractions. Have abnormality here in the progress of labor. You should put in mind that the patient may need cesarean section, so you should consider referral of the patient to the hospital with setting for cesarean section facilities. Put in mind that normal labor should be on or to the left of the alert line. Passing the alert line indicates an abnormality, and once you reach the action line, which is 4 hours to the right of the alert line, this indicates that an action should be taken. Here, a question: what is the abnormality in this partograph? Initially, on admission, 4 cm dilated cervix, 5/5 palpable fetal head. After 4 hours, the cervix become 5 cm. So this is an abnormal progress. After 2 hours, become 6 cm. Another 2 hours, 6 cm, and then become free. So here, the abnormality in this partograph is a primary dysfunctional labor or primary. Another question: what is the abnormality in this partograph? You see here on admission, it was 4 cm dilated cervix, then it become 8 cm, and later on remain on the 8 cm for more than 2 hours. So here the abnormality is the secondary arrest of cervical dilatation. We mention it as secondary because initially there is a good progress in cervical dilatation. Another question, what is the abnormality in this partograph? In this partograph, you see that the cervical dilatation was 4 cm on admission. After 4 hours become 6 cm, this is normal, and then become fully. Whereas the fetal head initially 5/5 palpable, then become 3/5 palpable, and then remain on this station for 4 hours. So this is a secondary arrest of head descent. You see this figure or table will help you in sometimes when the case is difficult to feel the fetal head abdominally because of obesity, over distended abdomen. If the station vaginally -3 or -4, this will correspond to 5/5 palpable abdominally. If it is -2 or -1, 4/5 palpable the fetal head abdominally. 0 station, when the lowermost part reach the ischial spine, it equals to 3/5 palpable abdominally, +1, 2/5, +2, 1/5, and +3 and more, nothing will be palpable abdominally. Thank you. This is the end of lecture, and you have this quiz. What is the abnormality in this partograph? And what is the cause? Mention the treatment. Good luck.